we have a special guest today. We have Dr. Ratzliff here with us. Hello, Dr. Ratzliff. It's so nice to see you, and we're so grateful that you're here joining us. One of the things that we thought would be a great opportunity is to invite Dr. Ratzliff. She is the co-director of the AIMS Center and a psychiatrist, and we've invited her here to really help level set and explain what is the collaborative care model and different components. And so with that, we are so grateful that you're here today, that you're able to join us. And Dr. Ratzliff, we are a very informal group. We're a pretty small group. You probably know some of the folks on here. So I just invite you to come off mute. And if you could explain to us what is the collaborative care model, I think that would be great. We just want to make sure we have a good understanding.
Great. I'm happy to do that. Thank you for inviting me. I do see a few familiar faces on here. It's really nice to see you, Tisha, again. I got a chance to visit some of your programs last year on a site visit, and it's always so exciting to see just all the good access to care people are building as part of the collaborative care model. So it's really fun to be here, and Patty and I know each other for a long time actually now, so it's very nice to see you as well. I do have a few slides, so I will try to share those. I don't know, it looks like I have sharing privileges. Okay, great. And let's see, can you see that?
Yes.
Is it tiny or is it big? Is it big enough? I can't tell on my own screen. So.
I think it's big enough for me.
Great. Okay.
Now it's great.
Okay, great. I can make it even a little bigger. Part of what I've realized is I can at least try to do some doing it in a different window allows me to still see you guys. So, all right. Well, so I co-direct the AIMS Center. I'm a psychiatrist by training. I have been doing collaborative care both as a clinician and as supporting practices for about 15 years, and now co-direct the AIMS Center, as you said. And for those of you that don't know, the AIMS Center really works nationally and even internationally to help practices start to deliver care as part of collaborative care. And we do a lot of work nationally to try to promote this model, including a lot of work on the billing code. So that is some of how I am connected to the people on this call. I, always start with and I don't think this is something I need to share too much with you guys, but, the reality is that most of the people, unfortunately, right now who need mental health care are not able to access it. And that's one of the reasons why I'm so passionate about this model, is really trying to see, is there a way to actually get this care out to more people? Especially when you think of about half of the people who have a mental health disorder not receiving treatment, and half of those, again, also wanting care and not being able to access it. So really important. And the reality is, as I think, again, many people know, most of the people who are receiving mental health services are really probably getting that care in primary care settings, with about 60% of the people receiving their care in primary care and only 40% receiving that in specialty settings, like in a therapist or psychiatrist or psychiatric provider's office. And I think, it's important as we think about this, and Tisha mentioned pediatrics, and anything that I'm talking about here is actually just worse for pediatrics. So just naming that out loud as well. And I think there's a variety of factors why people don't get services in primary behavioral health settings. And that's both, that a lot of people end up struggling to follow through on referrals. And I think some of that's around all kinds of different barriers to care and access to care, but also there just are not enough mental health providers to probably do all direct services. And this map is of the United States, and what you can see is anything gray there means there's like no one in those counties. And so you can see, and I'm sure you guys feel this, that, in some of our rural counties, especially, there may not be a provider, especially that has psychiatric prescribing as part of their as their core skill set. So I'm going to be talking a bit about this level between sort of primary care by itself, which is quite frankly where a lot of mental health care happens right now, and specialty care, where that's a primary behavioral health person taking care of that work. And collaborative care is really a model within the broader category of integrated care. And I always like to emphasize that there are a bunch of different strategies to deliver services in primary care settings to address mental health disorders. Some of the really unique pieces of collaborative care I'll cover in the next couple of slides, but one of the things I always like to emphasize, it's really a model designed to treat a mental health diagnosis to response or remission. So it really is focused on those patients that have a diagnosis of anxiety, major depressive disorder, or bipolar disorder, or PTSD. So really treating a diagnostic condition is really the focus of most collaborative care. So this is the collaborative care model, and I'm seeing, and I am also an informal person, so if you guys have questions along the way, like feel free to stop me. I just noticed, okay, that the chat button went, so I want to make sure there's nothing. Okay. The collaborative care model really came up first in the early 2000s, and it really was in response to a recognition that a lot of mental health services were happening in primary care settings, and really taking what was considered at the time like a chronic illness model of care and saying, how would that work for depression? And the first trials really were mostly around major depressive disorder. So I'm going to describe what the IMPACT trial was. That's the largest trial to date. That was 1,801 patients that were randomized to one of two conditions. They either were continued care with their primary care provider, as that primary care practice would always do. So they could refer them out, they could prescribe a medication. One of the organizations even had a therapist down the hall that they could refer to. They could do whatever they wanted to in terms of addressing that depression when it was showing up, or they received an episode of collaborative care. And this is what the collaborative care model looked like in that situation. They had a primary care provider working with that patient, and they really leveraged that relationship that was already established and added in two new roles. One of those people was a behavioral health care manager. The behavioral health care manager served two functions. One is care coordination of the whole team, and two, they generally were trained in brief evidence-based behavioral interventions that could be delivered in primary care settings, so that you really could then offer the full range of treatment with that primary care provider prescribing medications, behavioral health care manager delivering psychotherapies, brief interventions. And that whole team was supported by a psychiatric consultant. In the original trials, these were mostly psychiatrists. They were psychiatrists in the original trial. And that person had two roles. They did not see most of those patients in person. And that's why there's those dotted lines there to both the patient and the primary care provider, but rather put clinical input into the whole caseload through what's something called the systematic caseload review, which ideally is a weekly meeting between the psychiatric consultant and the behavioral health care manager, that's facilitated by a bunch of tools. And those include a registry to track the population of patients that have been identified as needing care. So that's essentially a list of 60 to 80 people that team is really focusing on. The use of validated outcome measures that were tracked over time, like the PHQ-9. So you'd have those lists of the scores, most recent scores and original scores in that registry tool. And then coming up with diagnosis and then treatment plans where you could really deliver the full range of treatment. So a lot of evidence-based treatment, including both medications and psychotherapies. So that was basically what the patients got in the collaborative care arm. That trial resulted in some pretty impressive outcomes. So at every single organization that was in that original trial, collaborative care or IMPACT outperformed the usual care, getting about twice as many people better. This was looking at 12 months recovery. You can see that you still don't get everyone better. It was about 50 to 60% of the patients got better, would get better. So collaborative care, again, is supposed to complement that whole kind of continuum of behavioral health, but you got a lot more people better when you actually delivered had a systematic approach to delivering mental health services in primary care settings. There's some other things that have subsequently been shown around this, and I really like to talk about the quintuple aim, meaning that we're actually able, this is a model that can improve access to care, can improve clinical outcomes, it can reduce total costs of care. There was some work done on the original IMPACT trial that showed that you saved about $3,500 in cost savings. A lot of those were medical care costs over the next 4 years after people had received an episode of collaborative care. We get really good provider satisfaction, and I think many providers also feel like they have increased productivity with the support that they get. Patients are satisfied with this, and then we also think there's an important role in reducing healthcare disparities, really improving health equity with equivalent or better outcomes. And just, to illustrate that part, these were the data from the original IMPACT trial, and you could see when you looked at racial and ethnic groups, they had equivalent improved outcomes compared to usual care. There now are over 100 randomized controlled trials showing that collaborative care is an effective model. It has all those core components that I just talked about. And so I think that's a really important thing to emphasize. So it's not just general collaboration, but actually having really specific providers with specific roles and the tools to support that care. And, I would say at this point, we also recognize that collaborative care is probably helpful for a diverse range of populations and settings. So perinatal, adolescent, older adults, cancer settings. It can be rural, low and middle income countries, FQHCs, low income patients. There's also like a range of conditions that collaborative care has a strong evidence base to be able to treat, including, depression, anxiety, PTSD, chronic pain, dementia, substance use disorders, and bipolar disorder. There's a little bit of an evidence base for ADHD and pediatric populations as well. So I just wanted to highlight sort of how we think about now building capacity around this, because I think this is really important. Like, collaborative care looks a little different in each setting, but there also needs to be those core principles in place for every collaborative care program if you're going to ideally get the kind of outcomes that we were just talking about, and also be able to bill for it. So most of the billing codes require these core components to be in place. That's team-based population care. So that's like a team wrapping around that patient. That's measurement-based treatment to target the regular use of measures. That's patient-centered collaboration with the team really surrounding that patient. That's evidence-based care being able to be delivered, so both medications and psychotherapy, although not every patient has both of those things. And that the team is then really accountable to monitoring their own metrics and making sure they're getting the kind of outcomes that we see in the trials, and if not, that they're actually adjusting how they're delivering care. So we always think, when we work with practices, they have to have those core pieces in place, although there's always a little adaptation for who exactly serves in that behavioral healthcare manager role, for example. So I just wanted to talk a little bit about the team. I, alluded to that triangle, and I think one of the things we've seen as we go out and do this in the real world is that there are some variation in sort of who's available to be part of that team. The little definitions that I included below come from the Medicare Learning Network series, which describes how Medicare defines the team roles in the Medicare collaborative care codes. In general, collaborative care is billed out through the primary care provider or the treating or billing practitioner. That tends to be a physician, or it could be a non-physician, but that's typically somebody like a physician's assistant or nurse practitioner that is in either primary care or primary medical role. Those folks need to be able to prescribe medications for patient care. there's a behavioral health care manager, and I think that this allows a lot of flexibility in who can serve in that role, but it needs to be a designated provider that has formal education or specialized training in behavioral health. Typical types of people that serve in that role are MSWs. We've seen nurses, in some cases psychology or like licensed mental health counselors. And ideally, they are collaborating with that billing practitioner, right? So the work that they're doing is going to actually be billed out under that treating practitioner. And then there needs to be a psychiatric consultant. And ideally, this person really has training in both the behavioral interventions and the psychotherapy and the medications, right? Because they're really going to be helping to provide diagnostic clarification to that team and also providing treatment recommendations across that full spectrum of treatment options. So for Medicare, that person needs to be trained in psychiatry and qualified to prescribe the full range of medications. So that is important to think about. And then lastly, we always think of the patient. They're not last in our thinking, but last on this list of people that we consider part of the team. So that's like a whirlwind. I was asked to give like kind of a little bit of an overview, but I wanted to leave plenty of time for questions. So I'll stop sharing now and sort of, I think I saw something come up in the chat, but I couldn't see it. So
Yes, we do have a question in the chat.
okay.
And I'm going to just read it out to you.
Sure.
If Tommy, if you want to come off mute and ask the question, you're more than welcome. Or
yeah,
add
I'd
to
be
it.
happy to.
Perfect.
Sorry, I'm not on video. Tommy Horn here. I'm a psychiatrist in St. Louis. Work with Mercy alongside Bree Strong, who's also on the call, I believe. And you see the model being used different ways, different specialties, and I love that. But as we look at the psychiatric consultant role specifically, what are your thoughts? Nurse practitioners, the training is so varied often. A lot of times there's not that robust psychotherapy or behavioral modification training, maybe a little bit less in the medication management too. But yet, from a cost perspective, it's much cheaper to provide that. So I see places are going to be increasingly using psychiatric nurse practitioners, and I just worry about a little bit of maybe quality and patient experience with that. But is anything available as far as studies or anything the AIM Center is doing to look at that?
Yeah. So I do not know of any formal research that have compared the like collaborative care outcomes and using different providers, like a psychiatric nurse practitioner versus a psychiatrist in the psychiatric consultant role. I will share a few of my experiences around that. I think if you were to use a psychiatric nurse practitioner in that role, it would need to be somebody who's not just straight out of school, because I think you need to have a certain amount of confidence in your direct care to then be able to do indirect care. And that's both what I've seen from some practices that we've supported, but also just my experience in training residents. So I trained a lot of our third year residents, or started to try to train our third year residents in collaborative care, and found that they could certainly participate, but they didn't have enough experience of their own to really then be able to leverage that, I think, in an effective way through the team and feel confident in their ability to do that indirect assessment, right? Because as a psychiatric consultant, you're mostly relying on the assessment of the behavioral health care manager and primary care provider and notes and things like that to be able to make it both a diagnosis and treatment recommendation. So when people are thinking about using anyone other than a psychiatrist, I encourage them to really find someone ideally that has a lot of experience, because I think that is really needed. I would say the other thing that I will say about that is that it's really important. The accountable principle is really important in collaborative care, because essentially, I think whoever you put in that role, I mean, it could be a psychiatrist too, like you need to make sure that team is able to get good outcomes, right? So you have to be measuring whether or not your patients are improving. And if they're not, then I would think about looking at anyone on the team, and whether or not they need additional training or support to be able to really work together. There's also systems things that sometimes need to be adjusted, as I'm sure Tisha can attest, and anyone else on the call who's run a team. But I think that accountable principle is really critical, especially when you start, adapting the model from what that core evidence base was really around. And I do think it's really valuable. Like in the original impact trial, you asked about psychotherapy training, and I think I just want to spend a second on that. Like in the original impact trial, like the majority of patients had both medications and psychotherapy, but like there also were like 20% of the I don't remember the exact numbers, but a smaller percentage of the patients that only had meds, and another percentage that only did therapy because of patient preference. And I think that's a real strength of collaborative care, to really be able to develop treatment plans that incorporate that range of evidence-based treatments for whatever the major diagnosis is. So it's really important that whoever serves in that psychotherapy, like the psychiatric consultant role, is comfortable like talking about that full range of treatments and thinking about that in partnership with the behavioral health care manager. I hope that helps answer the question.
Oh, super helpful. Great point on accountability. And yeah, with our internal program with Mercy, we're talking therapy all the time. So I hear you loud and clear. Thank you.
Honestly, I'll say in my own experience, treating patients, the meds are pretty easy. Like, I mean, honestly, sometimes there are not as many choices in the meds as there is in terms of thinking about with that behavioral health care manager, what else is going on? What are the psychosocial contexts, and how, what are some ways we're going to think about that for this patient, right? So, I appreciate hearing that resonance with that.
Yeah, I want to kind of just echo that a little bit. I feel like that sometimes whenever people see like psychiatric collaborative care model, and our doctors are the same way, they just think medicine, medicine, medicine. And while that's a really important piece, and we need to have that as, as something that we're thinking about, a big piece of what we do is trying to figure out like, how do we help this person get better? And a lot of times that is no, I mean, it might be like adjusting and making sure that they're taking their medicine, and it might be that, they've tried a couple of things and things aren't working, but a lot of it is how to, what are the things that are impacting their function in their life, and most of that has to do with their behaviors. And we are been very fortunate at UAMS to have our psychiatrists are very behaviorally trained and think about things that way. So it's been really helpful for our team.
Absolutely. It sounds like the perfect combination. And when I hear you talk and say the medications are the easy piece, I'm not a psychiatrist. I am a social worker by training. But these behavioral interventions, and when we do check-ins, if patients aren't increasing, then what's going on, and trying to adjust those interventions. One of the things we know collaborative care is a population health model. Would you be able to talk a little bit about that piece?
Yeah, I mean, I think I would think about population health from two perspectives. One of the ways we think about that is that this is increasing access, and is a way, when we really think about like, how do we think about the health of our communities to increase the number of people that are able to access high quality evidence-based interventions for their mental health disorders, right? So by building that capacity out in primary care, ideally there's going to be more people actually accessing the care that they need. So I think that's one of the dimensions of population health that I think about a lot. I think the other piece that I think about is that in our actual teams, we're going to focus on a population of patients that are in active treatment, and we're going to track them on a registry. So that's a foundational and required piece if you're going to bill for collaborative care. And part of what that allows you to do is really help that primary care provider and sort of remove that burden from them of having to say, when did I see Sally again? Did she come back? Did she cancel her follow-up appointment that we made. You know, it really gives that role of tracking and doing proactive outreach and engagement to patients that have been identified as needing help, to actually get it, and being a little persistent about that. I think that's really critical, because unlike, you know, an earache where, like, if you're not feeling better, you're going back to your primary care doctor, right? Like, if you still have pain, then, you know, 2 days later and it isn't just feeling like a viral thing, you're going to go back to your primary care provider. The problem with depression and anxiety and PTSD and most of the disorders and mental health conditions is a primary symptom is deactivation. And, you know, I mean, you could even characterize that as avoidance, but I mean, I think it's mostly lack of energy, lack of concentration, some of these things that are really critical if you're going to go back on your own, right? So when we tell a patient in usual care, here's an antidepressant, come back if you're not getting better, when they don't come back, we don't know if they actually got worse or if they got better, right? And so one of the things that I think collaborative care really does is have somebody own that role of proactively reaching out to people and continuing to engage them until we have good evidence that they're either better or that they're going to need more support than we can offer in primary care. And then, you know, that shifts to supporting them to really make that transition to some kind of specialty setting. But, you know, so that's the other piece that I think of when I think of population, is that we're owning the care of that population. And then lastly, I'd just say, you know, it is an episode of care, and usually that means it has a beginning, a middle, and an end. And that's important too, because you have to graduate people back to usual care to have capacity to take on the next group of people. I think that next group of people is part of population health, because I think as a psychiatrist, I often was like, I'm not only responsible for the 60 or 80 people on my caseload, but the other 100 people in the practice that have depression, and I haven't actually seen them at all yet, right? And I'm always trying to, it is like a little bit of actually like owning the reality that like we have limited resources and we have to be thoughtful about how we leverage them over our whole population that we're responsible for. So I often felt like that was definitely something that we talked about in our psychiatric caseload review, of like, who's ready, who is like better enough to kind of move on so we can open up capacity to that next person who hasn't gotten anything yet. And so that's I mean, I guess I would say that's the other, you know, when you're thinking about that caseload, that's the other dimension of it, is like having some reasonable level of turnover so that you can create open capacity for that person who's going to come up that week, right, that has a new episode of depression. Does that help? If anybody else has other thoughts, there's other people who are collaborative care team members here that can answer that too.
No, that's really helpful. And I think you had a hard stop today, so I want to be mindful.
I'm actually okay. It was my colleague who did, so I can stay on for up until 11. So my time. Okay. So that's 1 your time. I'm sorry, I'm trying to do the math quickly.
No.
Not very good at doing that, especially with.
Yes, we've got some time then. Awesome.
Okay.
I think we're going to have some
measures of effectiveness of collaborative care. It looks like just came in.
Yes.
So maybe we can talk a little bit
That would
about
be
that.
Great.
I guess I just want to ask, like, at the patient level or at the clinic or organizational level, I just want to make sure I'm talking about the right level. Okay, both. Yeah, let's talk about both. So I talk about this a lot, the accountability piece, because I think that's actually really, really important. So I think at the individual patient level, I will say, like, pick a couple of measures and do them well. So, I mean, this is my own personal strategy. I think sometimes we get in our own way trying to let perfection be the enemy of the good, you know, in the sense that, do we have a perfect measure to measure everything, every different disorder? And should we have 10 different measures because there's 10 different diagnoses that we're targeting? I would say, you know, be thoughtful about it, but I would actually start with like getting really good at the PHQ-9. And I'll just say my experience has been, with a few exceptions, most of the time, it was a pretty good measure of how people are doing, because it covers like sleeping, energy, you know, all of these things that are kind of core, like functional domains, actually. I mean, people are like, well, it is a functional measure. And I'm like, yeah, except for if you're not sleeping. I'm probably 100% sure that your life is not going quite as well as you would like it to be going, right? So it's not perfect, but it's a good place to start. So I would say pick a measure at or three, you know what I mean? Like we often use the GAD-7 and the PHQ-9 to do tracking over time. In pediatric populations, it depends on the age. So, we're seeing teams that are treating adolescents kind of using those measures still. Teams that are treating people under 12 are probably using other measures that include like parent or teacher assessment. So I just want to acknowledge the pediatric range looks a little different. It's helpful to know like what are the core things you're going to be targeting in your team, right? So if you are going to use a target substance use for disorder, for example, there are other measures that you might need to add in to be able to address that. So pick measures that are aligned with the most common things in your population is what I would say for the patients, and start simply with one or two. And if that's going really well, then think about, are there other measures that we want to add into our mix? In part because every time you add that, like in your registry, there's now another column you have to pay attention to, and all of these other things. And it's just worth thinking about the benefits of adding additional patient-centered measures versus the potential downsides of that. So that's at a patient level. At a clinic level, I like to think about, again, like, what are you trying to accomplish, right? If your main goal in having collaborative care is to increase access, then you better have a measure of access that you're monitoring, right? And I've seen practices use their wait list as a measure, because ideally whatever measures you're using are relatively easy to get. The problem with most people, I think, is that they design metrics to monitor their program that are too complicated and take too much work to get, and then you don't look at them regularly. So I would say pick a imperfect proxy for something that you can see really easily over a perfect proxy every time. So that's my general guidance around that. If you are in alternative payment models where you need a certain outcome of a response in a PHQ-9, probably should be one of the measures that you're targeting and looking at as a group, right? So, I always think there ideally should be a patient outcome measure there, just because I feel like whenever we're doing anything a little, innovative, like we have an extra responsibility to make sure it's actually getting the job done and getting patients better. So I always would include a patient outcome measure. And then I like thinking about that quintuple aim, right? Like that's a good thing to take buckets of metrics to consider, right? So population health, are you getting the access? Are people getting better? Provider satisfaction, do you need to and that could be an informal evaluation, like asking at the provider meeting, how's that going twice a year? It doesn't have to be a big survey or something to be a quality metric, in my opinion. Patient satisfaction, and I think you've done some patient satisfaction, actually, I don't know. Anyway, there are patient satisfaction sort of things that people have looked at that some programs really consider. Cost is something I think we always have to look at. And I mean, it might be like, is the program covering its costs, right? Like that might be a reality bound measure that you have to look at. Now, I will just say it usually takes a while to get a program up to full sustainment. So I just want to acknowledge that can sometimes be a little bit of a challenging one. Yeah. And then the last one is I always am thinking that it's important to be looking with a health equity lens. There's some data that have come out more recently that when in Montefiore, they actually looked in their system, they saw great outcomes, when they were looking at racial and ethnic disparities, whatever that looks like in your population, who are the people that might not be as able to engage. And they saw equivalent outcomes, but when they actually looked at how many people made it from identification into the program, they saw a differential in how many people engaged, and with less people actually engaging in their racial and ethnic disparity populations. So I just name that, I think increasingly we should probably be looking at our data through some different lens. That might be social determinants of health, right, index or something like that you're looking at. All right, suggestions on how we can leverage collaborative care over traditional routes, decline in referrals and providers opting therapy. over collaborative care, either to be hands off or not as comfortable, to not have a desire with med management. Yeah, knowing the statistics on referral follow-up, just curious if you have suggestions in this area. Yeah, this is not an unusual thing that I've been hearing, is some tension, I think, between like, yes, we support the primary care provider, but they still are taking an active role, and like, you know, that versus referral out to, you know, other services. I would say the things that I think are most helpful in this area are trying to get some data and share it back with your team, right? Like, you know, maybe having somebody really track how many of those referrals actually were completed and the person started to get better, right? Like if you're just, it sometimes can feel good as a provider to provide the information for a referral, but if no one's actually getting to that care, I think providers would actually want to know that. I mean, my sense of my PCP colleagues has always been they are very patient centric, and they, you know, I think they want to do the right thing by their patients. You know, if there is access to direct specialty care and that gets the job done, great. If if not, then there really should be a pathway to like recapture those folks, or
Yeah.
you know, to try to look at that. I don't know if that's helpful. If you want to ask anything out loud, Sarah.
Oh, yeah, no, that's absolutely helpful. Thank you so much. And we've just seen that in the last few months and kind of wondered if it was consistent across the board or something with some of our newer providers. But all in all, we are tracking the data, and, you know, I'll report back to this team if we find anything there. But it is interesting to see the changes, and we are kind of working to integrate with a different line of business to give our collaborative care patients that may be needing that traditional route access to outpatient services that are still within, you know, our network and their insurance network. And the other thing that's coming up here is just different workflows, you know, working with Optum, now Carelon. Now, before we can verify their insurance benefits for duplication of services, we have to get a release of information from the patient to us from Carelon. So we've just seen some changes in insurance kind of overall, and wondered if that might be a contributing factor. Just looking ahead for the patients we serve, and more specifically, I think to the rural communities that, you know, definitely need this service, and, you know, affordability comes to mind with that as well, and the changes to some of these insurance paths to either get their insurance benefits verified or even the coverage for services. So probably all builds into the puzzle there, but I appreciate your insight and expertise today.
Yeah, I guess I'll just say two things. I mean, primary care providers, like, I always have to remind myself, like, my whole world is mental health care. So I'm like, why are they not as focused on that as me? Because they also have 1,000 other things that they have to focus on, where there's changes in standards. And, you know, being in primary care is always like a really good reminder of like what an intense pace and place that is. So whenever I see that from PCPs, I'm just like, oh, you know, I would also be a little curious, like, to ask them, is there anything that's making it you less likely to opt for this, right? Like, I mean, maybe having, you know, 5 minutes or 10 minutes on a provider meeting to just say, like, what's working well, what could we improve around
Yeah.
the whole referral process to collaborative care? Because it could be that there's really simple things like, it would be more helpful if you gave recommendations back in this structure, or wow, this like part of the workflow is really hard for me. Is there anything we could do differently around that to actually have that be more smooth, right? Like if that payment piece, like checking insurance and all that, somehow is feeling like an extra level that they're responsible for, is there any other way to address that? Like, I don't know what that would look like exactly, but I think getting really curious about what's making that hard. The other thing is people just forget about it over time. Like,
Yeah.
I really remind my practices that I would have like a standing agenda item like quarterly on like an update from collaborative care or something, if you can. Like literally 5 minutes, where it's like, here's one patient success story, or here's a little data from our team, or something to just remind people that this is like an option. Because people get busy and they sort of, if they didn't have a patient for a couple of weeks, they might sort of have forgotten how to do it, and then they're like, oh, it's too much work to remember how to like get that person to the to the collaborative care again. So I think that's part of like sustaining or maintaining your program is continuing to like promote success stories and just remind people of how to get access for their patients for that and making it really easy. Like, you know, so anyway, those are just a couple other thoughts that I've seen be helpful with other practices that see that.
Yeah, absolutely appreciate that. It sounds like we are aligned with that. We're going to start having our program managers, myself and another, go visit our practices too and kind of talk to them. So thank you very much.
Food also always makes it a little easier for people to want to chat with you about stuff.
Oh,
so,
yeah.
Yeah, I mean, I think that actually just going out and even just sitting in their pod area or whatever and saying, you know, hey, anything that can be helpful. Another just like thing I've seen is like if a care manager, you know, if they're seeing somebody who isn't referring regularly, putting the care manager into one of their like 15-minute slots to just go remind them about the program, make sure they know who the person is, say, hey, are there any people that you think might benefit from this? Let's get their names and get them, you know, we could reach out to them for you. Like that can be a really like helpful thing too, because you know, if there's somebody who's maybe more hesitant and hasn't had a chance to ask those questions in the bigger meetings, sometimes having that individual connection with the resource, and that could be virtual or real time, whatever your the care setting is. It doesn't have to be face to face.
That's a great idea. We don't do it with care managers. We do have EHR communication going on, but I think that's a great idea to help expand and, you know, show them who's treating their patients and working with.
And just engagement, you know what I mean? Like just making sure that people know who that person is. I mean, I think that the highest functioning teams, people feel like a team, right? So the more you can promote that in whatever way that looks for your configuration, I think it can be really helpful.
Thank you so much.
Yeah. Great question, Sarah. I have a quick question, Dr. Ratzlaff. I wondered if you could talk a little bit about CoCM with the pediatric population. One of the things that we have been asked, specifically, Medicaid has been the recipient of this CoCM grant. They've said, how could we use this with our pediatric populations? And so wondered if you could speak to thoughts and ideas on where you see programs with CoCM and pediatrics working well, and what does that look like?
Yeah, we're working with New York State, and they received a SAMHSA grant as well. So they're on their second cohort. What they did is specifically recruit practices that either were family practices that were serving a lot of patients with pediatric patients, or pediatric practices that maybe wouldn't have traditionally been, you know, likely to engage in building the capacity for collaborative care. And so they've sort of engaged those practices in a learning community to actually support implementation. So I think there were 5 practices per cohort, and it's been nice because I think collaborative care, there's less rigorous evidence base for collaborative care for pediatric populations. It's just true. And there are a broader range of needs around behavioral health, I think, in pediatric settings. So I want to acknowledge both of those things up front. Like, again, collaborative care is really good for diagnosable mental health conditions. That's what it's designed for. There's a lot of like behavioral psychoeducation that needs to happen, I think, in pediatric practices, you know, that's more short term. So just also thinking about like practices that would have enough need for, you know, actually collaborative care, I think is really worth talking about as people think about that. So those are some ideas around like maybe doing some learning communities, identifying practices and really helping support them getting through the workflows, because in many places the pediatric practices haven't necessarily like done as much like implementation sort of work and all that workflow work and all those things. You know, I've seen some interesting places trying to think about also how do you sort of, if you guys have like a child access line, which most states do these days, I just don't remember about Arkansas. You know, I don't know if you have that where people can do one-time consults for pediatricians to child psychiatrists. We have that in Washington State. Like anyone can.
We have a grant through Children's where they're doing some of that now.
Yeah. So kind of also thinking about, are there practices that are utilizing that a lot and might want to build more capacity internally? Like that's an interesting question to think about. Maybe even where you might identify some practices that would be interested in thinking about capacity building. Because to me, that's sort of like level one of support is a one-time consult, right? And that can be helpful, but for those patients that actually and families and caregivers that is often that patient is sort of expanded in pediatric practices to include the family and caregivers who need more support or engagement than the PCP can offer on their own. That's where collaborative care can really come in and be very, very helpful. So that might be a way to do that. And I think this isn't I think a lot of child psychiatrists know about this, but I don't think that it has not been quite as like advertised in pediatric like circles as much as maybe family medicine and internal medicine and some of those other settings. So I do think there's some also just general community education about what collaborative care is, what it does, that it's a real process to implement it. It isn't just hiring a couple of people and hoping beautiful things happen. And then in other states, like North Carolina is another state that's done a lot of work in this area. I think they actually offer, like, we license a registry tool for our as part of the AIM Center, and we have a pediatric version, and like they made that available to practices. So that includes, I think it includes the Vanderbilt for sure. I think it has the SMFQ, which is for like more for mood stuff for kids, and the scared, which is anxiety for kids. So yeah, so I mean that's another thing that's like centralized you could offer supports like the registry tool, because building that can be a big barrier to implementation. So I'm just giving you guys like some ideas, and they're not very organized, but hopefully that's at least helpful for a range of things you might think about.
This is fantastic. This is exactly what I was wanting to hear. So thank you so much. It's very helpful because, sometimes you get these questions and it's like, whoa, there's a lot of moving pieces. So I'm glad you said we can't just hire people, put this in place and expect beautiful things to happen, right? It is a process. We have to build this foundation. And I love the idea about the education. Maybe doing some type of presentation at our pediatric conference on what is CoCM and how would this look?
And some of the things we've done around that, we actually just did a whole workshop at ACAP, which is for Child Psychiatrists National Association, and we modeled something like we talked about what a program can look like. We modeled a little systematic caseload review so people understood like what does that indirect care actually look like, right? And from a pediatrician's perspective, why would getting a like really like edited, efficient recommendation be helpful to them, right? And what is the role of the care manager? Why would you need that, and how could that be supportive to your practice? So and then we see all kinds of innovations happening. Like one of our programs also has a community health worker that's part of their team, in addition to the care manager, to really be able to like engage with some of those psychosocial needs that maybe are beyond the scope of what the behavioral health care manager can do if they're managing a big caseload of 70 to 80 people. So, also getting a little creative, like what are the needs in your pediatric, like in those conversations, it'd be interesting to identify what are the needs in your pediatric patients and what might a team look like to address those.
As you're saying that, we have a fairly robust Healthy Steps program here in Arkansas for 0 to 4 and 0 to 3, but up until their 4th birthday. And so question, might be, what could practices implement something like this in their pediatric practices to try to then support and bridge those patients after the Healthy Steps program?
Yeah, I mean, I think that can be really great, and really think about the continuum of like, what are our resources for 0 to 4? What does 4 to 12 look like? And what does 12 and up look like? Because I think those are sort of natural divisions in the child. Well, I'm not a child psychiatrist, but I've been now supporting a bunch of these practices. So at least I won't do the clinical stuff, but I'll happy to talk to you about the context. And I think really thinking about what are the needs for each of those. There are also some specialized trainings out there for people working in primary care. So we have a whole series that our children's hospital offers called Fast Skills, and they have like parenting stuff. Those are brief interventions that a care manager can deliver in primary care settings or primary pediatric settings. And they have some that are targeted more to parents, like parents for disruptive behaviors. There's like a more parenting focused intervention that the care manager can deliver. They have them for anxiety and depression, sort of for a range of ages. And then they also have a parenting teens version, which I think people have really found building up the skills of the people who are working in those settings to deliver evidence-based skill sets in, you know, efficient context has been another way that they've sort of optimized, you know, how to utilize that collaborative care team.
This is extremely helpful. Thank you.
Yeah, happy to talk again too. I mean, if any of you want to have a longer conversation about your particular setting, you know, happy to do that or have my team connect with you as well. So I probably should run to my other meeting, but I really appreciate the invitation. I hope this was helpful. I know you guys are doing a lot of amazing things. Very exciting. Happy to help if I can be of help in the future too. So
thank you for your generosity by spending this time with us.
Thank you, Anna.
Thank
you. All right. Take care.